So because Manish sir has to leave for some sessions, so he will be taking on today. So let me have the opportunity to welcome Dr. Manish sir, who has been my senior, and sir has always been a guidance for all of us to keep moving. Thank you so much, sir, for being with us. Over to you, Manish sir.
Thank you, Dr. Sweta, for such a humble introduction. And good afternoon, everyone. I was listening to Reena Madam, and it was such a mesmerizing presentation that I don't think there is much left to be said after this presentation. But definitely there will be some repetition. I'll also try to highlight the role of structural progression and evaluation of structural progression. So as one important point which I like to share with the audience that glaucoma diagnosis definitely is difficult at times, but personally over last a decade or so of my glaucoma practice, I believe assessing progression is probably even more difficult than diagnosing glaucoma. And it's even more important because slide is not changing. Okay. Yeah. So progression can be structural and functional. So I'll be focusing on the structural progression. Dr. Sweta, am I audible?
Yes, sir, you are audible,
yeah,
sir.
okay.
Audible.
Thank you so much. Yeah, so very briefly, we know that structural progression precedes functional progression because any glaucoma to be detected on a visual field takes at least 40 to 50% of RNFL damage, and we can detect a structural progression much early. In fact, there are studies which have shown that almost 4 to 5 years earlier, you can detect changes on the OCT or even a clinical evaluation, and much later on a visual field. Now, how to detect structural changes? There are multiple things reported in literature. For example, you have the HRT, GDX, OCT, and just a serial disc photography. Currently, HRT and GDX are not freely available, so we are focusing more on the OCT, and disc photography is always available. Although functional progression is not part of my presentation, but things like change in vision, contrast sensitivity, perimetry, definitely, even a color vision and electrophysiology are useful to see the functional change of the eye over time. World Glaucoma Consensus has very nicely said that in glaucoma diagnosis and progression, what is the change in RNFL and in neuratal limb? That is something needs to be focused on for a clinical diagnosis. Let's first start with a simple slit lamp evaluation. Even on a slit lamp, if you are properly evaluating your disc and documenting it, sometimes you can detect certain changes which you will be seeing on fields much later on. However, it is often possible to miss certain changes which you will detect on a photography or maybe an OCT evaluation. I'll share this example. Like this particular patient came to us in 2019. It was a simple disc drawing which was done on my file. Now, again, after lockdown, recently he came back. And when I was drawing the disc, I could feel that definitely there is a fresh RNFL thinning superiorly and a small disc hemorrhage. So we cannot quantify it, but a proper disc drawing can actually help us understand whether there are structural changes or not. And this is something which is possible in any setup. Coming to disc photography, this is extremely useful. Again, the problem here is there can be inter and intra-observer variability, and the quality of picture at times is the issue. Not every picture is very good, and most of us are not actually doing a stereo photography. But a very big advantage with this photography is that there are patients whom I have seen, say, 10 years or 15 years back. Now also when they come with the old photograph and when I'm examining their optic nerve, I can get an idea how things have changed over a decade or so. Compared to an OCT or 10-year-old back OCT with the old version of, say, a Stratus machine, currently is not that useful. So this photograph are useful on a long period of time. Like this is a case which we saw clinically. We found that there was some inferior thinning. We took a disc photograph, and when we saw the disc photograph, it was very nicely taken disc photograph. You can see there's a small disc hemorrhage which was actually missed on clinical evaluation. So sometimes a good disc photography can give you an added information you might have missed on a busy OPD when you're hurrying up with your patient. And again, serial disc photography can give you information. For example, this particular patient, you can see this is a 5-year follow-up. After 3 to 4 years, patient developed a disc hemorrhage and there was some inferior thinning which was not present initially. But the visual field over the whole period of 5 years is maintaining normalcy. So serial disc photography, properly taken, proper centration with good clarity can give you an idea of changes over time. Coming to progression on OCT, most of us are now using a spectral domain OCT, which definitely is faster, gives you more information. gives you better resolution compared to time domain OCT. Important thing, you need to understand that different machines of OCT can't be compared. So if, like for example, in our setup, we have a Topcon machine. We also have a Spectralis. So the two machine data cannot be interrelated. So whenever you are trying to see a progression, you have to do test on the same machine. There are multiple parameters we can see on OCT. For example, the RNFL is most important. Apart from that, you can also see the ganglion cell complex and the optic nerve evaluation. There are OCT guided progression analysis available in most newer machines. For example, like the Cirrus, we have both the event and the trend analysis. Now, often there is a discussion that how much change in the OCT should be regarded as significant. When used to use the status OCT, it was around 10 to 12 micron. Nowadays, most studies, especially by Dr. Singh et al. And his group, they have shown that anything more than 5 micron, you should think that probably you are having a change over time. There can also be an age-related change, but the age-related change is almost always less than 1 micron per year. So if you have more than 1 micron per year, it should raise a suspicion I might be getting a progression. And I have to share this particular case by Singh et al., where they have shown a follow-up of 7 to 8 years using an OCT event and trend analysis and the visual field, and they have shown that the event analysis almost detected change almost 2 years before that and 4 years before the change which was seen in the visual field. So a serial OCT using same machine, same software can detect some early changes compared to what we get in a visual field. But OCT has its own fallacies. For example, we know that in advanced patients, in advanced glaucoma, you can have the floor effect. And so because of the presence of glial tissue and remaining non-neural tissue, OCT will never show an RNFL thickness less than 50 micron, almost never less than 40 micron. So in advanced glaucoma, you will always have the problem that after a particular stage, you will see that the thinning is not being shown on OCT. I'll share this example. This was one of my friends' photograph. He had purchased a new Cirrus OCT, and you can see the RNFL thickness showing in the left eye superiorly was just 21 micron. And if you compare it with the TSNAT graph, it is almost touching the baseline. And on the thickness map, you can see superiorly there are some black areas indicating the data was missing. The reason I'm showing this, sometimes when you're purchasing a 50 lakh rupees machine or a 1 lakh rupee machine, where the company will claim that it will always have well-centered and clear photograph, don't get biased. Even in a high-end machine, like say this is a Cirrus machine, you can see this type of artifacts can be there. So we cannot blindly just see the report, see the red areas and jump for diagnosis. You have to see the patient in totality. And as I was telling you, if you ever see thickness less than 40 micron, you should always have a suspicion. Madam has already touched about the macular scan. We all know that macula has got almost 50% of retinal ganglion cells, but the area of macula is just 2%. So there is a very high concentration. Here also more than 5 micron is regarded as suspicious. There have been various studies which have shown that macular scan is as good as RNFL evaluation for seeing progression over time. Again, different machine actually check different things. So you can't compare a Cirrus data with a Spectralis or OptoView data because they are actually not measuring the same thing. Floor effect thankfully comes much later in macular scan. So in advanced glaucoma, they can be better than RNFL evaluation. Very quickly about the trend and event analysis, most of the newer machines they have, for example, this is the Cirrus machine with the GPS software. So trend analysis basically is the change you see over time, how the thickness is going down. And event analysis, you have a point-by-point progression where you can see the new areas and you can highlight which area you are having changes which were not present initially. I'll just touch about the few artifacts which can give you a false idea of progression. For example, if suppose you have problem with the clarity, say suppose there's a cataract or media opacity and you have got low signal strength, it can give you a false sense of progression. Similarly, if you can have a segmentation error, for example, this particular patient had some cataract, the clarity of media was not good. If there's an ERM or a CME, you can have a problem with the segmentation. So these cases, machine will give you a false thickness and always try to clinically correlate with your finding. Optic nerve head evaluation is less useful compared to a macular scan or RNFL. Mostly it's not used because there is lack of normative database also. So mainly we see the RNFL and the macular scan. Again, madam has already touched about the OCT angiography. There are data that OCT angiography can provide some additional information which may not be available on OCT also, but there have been few review article. I like to share this particular very recent review article in Journal of Glaucoma 2020, where very nicely they have compared OCT angiography with OCT RNFL evaluation, and they said in the current glaucoma practice, OCT angiography still not can be used for progression, but over time maybe it can be a good tool to see progression of patients, especially patients with early to advanced glaucoma. So to conclude, I'll say OCT is a good machine, but we have to know its limitation. As I was telling you, the machine sometimes changes, the software changes even before the disc has changed. So say 5-year, 10-year-old photographs sometimes may not be very useful. The current progression software which are there, they don't account for cataract or dry eye or age-related changes. So don't blindly go by whatever the machine is showing. You have to have a clinical correlation. I'll just end with this particular study, the Advanced Imaging Glaucoma study, where they have directly compared OCT and visual field in patients with pre-perimetric and established glaucoma. And they found in glaucoma suspects and pre-perimetric group, here OCT has a better advantage over a visual field. But in established glaucoma and advanced glaucoma, definitely visual field is better than RNFL. But yes, if you're using a GCC also, that is a macular scan also, then a combination of a macular scan and visual field maybe give you more information than visual field alone. Thank you so much.